So I've been tasked with KRD and VRD for initial therapy for young fit patients. Those are my disclosures. So I think, as we know, there's a lot of factors that go into picking the right therapy for a patient. There's patient issues, the disease burden, the disease biology, and if patients have been previously treated, their prior toxicity, which is not as applicable here, but certainly we need to think about the toxicity of the regimens, the route, and the cost. So for the purposes of this discussion, who are we talking about for the young and fit? I think it's even patients over age 70 can undergo transplant. For the purpose of this young fit, I would say we're talking about below 70, good performance status, adequate organ function by both cardiac and pulmonary, no concurrent multi-organ amyloid, adequate stem cell harvest, and no active infections. So our goals of therapy are the following. We want to obviously improve the benefits, first and foremost, overall survival, although that's getting harder and harder to show with initial therapy given the number of salvage options available. PFS, we want rapid, deep responses to reverse the CRAB symptoms, quality of life, maintaining the collection, overcoming high-risk disease, and trying to attain minimal residual disease. And at the same time, avoiding death, toxicities from the treatments that are listed, clonal resistance, and how that might impact second PFS, and then patient and healthcare costs. So to go back, these are the initial doublet regimens that showed relatively modest response rates, Thal-Dex, bortezomib-dex, and Len-Dex, either high or low dose dexamethasone. And we see that the CR rates are relatively low, 5 to 15%, and then the VGPR rates are anywhere from 39 to 50%. These were for transplant-eligible, newly diagnosed patients. So this was the important paper that just came out for newly diagnosed patients comparing RD to RVD. Interestingly, this is probably the triplet regimen that's been used, as you saw from the survey, most widely in the US, but in the absence of phase 3 data until this came out. Importantly, the bortezomib in this study, when it was designed, was given twice weekly intravenously, and that, I think, will pertain to some of the toxicities, and compared to RD standard dose and schedule. And we see here that the AE rates were higher for the addition of bortezomib, including neuropathy, both sensory and pain, and also GI toxicity. But again, a lot of this is in part due to the intravenous twice-weekly nature. What about the efficacy? We see that the response rates were superior, 81.5 versus 71.5, including the deeper responses were superior, CRs 15.7 versus 8.4. PFS was superior, 43 versus 30 months, and OS was also superior, 75 versus 64 months. So I think this answers what we've been all doing for a while, which is using RVD induction therapy superior. Can we do better than that? This was this patient advocate-led study that randomized patients to high versus low-dose dex, and it was a good example of how more is not always better, and the use of high-dose pulsing 4 days on and off actually led to inferior overall survival. So more is not always better. This was the Mayo study, that the evolution that compared these different triplets, and at the table at the bottom you see quadruplet with the RVD with the addition of cyclophosphamide, RVD, Cybor-D, and then modified Cybor-D. And you might think that, oh, adding 4 drugs will give you better responses, but the response rates were there, 88%, not significantly different. Admittedly, this is a relatively small randomized study. However, it did come with increased neutropenia. So yet another example of more is not always better. This was the important study that just came out, which is the comparison of transplant after RVD induction, cyclophosphamide mobilization, stem cell transplant, and the control arm got RVD consolidation, and both arms got Len maintenance. And this again showed deeper responses with the use of transplant, CR, VGPR, and MRD negativity all favoring the use of transplant. And also importantly, PFS was superior, 50 versus 36 months. 4-year OS was not different. However, this was relatively short follow-up. And again, going back to the availability of salvage regimens as well. What about KRD? This was led by the Chicago group, where KRD induction was used, followed by consolidation, maintenance, and transplant was allowed as well. And what we see here is that the VGPR rates in better are very impressive, 85% after induction. And as the patients continue on with therapy, You see that the MRD negative CR rate goes from 60% all the way to 100%, although it's important to note that not every patient is being sampled continuously, but clearly showing that KRD is an outstanding regimen. And in this debate, you could argue, well, does this matter? How important is the induction regimen if you're going to go to transplant anyway? And this shows that the MRD status post-transplant, even in post-transplant CR, matters. It does lead to improved overall survival, and not reached median OS versus 82 months. So I think this argues that we do need to use our best regimens pre-transplant to try to get those MRD negativities post-transplant. And so what would that regimen be? This was the IFM study comparing VTD to CyBorD, and shows that, again, the deeper responses are seen with the use of the IMiD, both VGPR and better as well as PR and better, favoring the triplet with the IMiD. This is not a prospective randomized study, but from the Commpass study through the MMRC, looking at CyBorD versus RVD, which is the regimen that kind of, if we haven't seen this as a prospective study, but also showing that RVD led to better PFS on the left and better OS on the right, but clearly supporting the triplet with IMiD combinations. Recently, we also heard from the group, from Italian group KCD versus KRD. This is basically standard carfilzomib dosing in terms of twice weekly at 36 milligrams per meter squared. And the cyclophosphamide arm had 300 milligrams per meter squared weekly versus the other arm had len, and both got the same dex with Cy mobilization. We saw that the AE rates were generally comparable. Heme-wise, the grade 3-4 toxicities were comparable, but there was slightly higher thrombocytopenia with the use of lenalidomide, grade 1 and 2. Non-heme toxicities, as listed, were primarily dermatologic, hepatic, but there was interestingly no difference in cardiovascular AEs. The dose reductions occurred primarily for len, 15% versus 6%. Stem cell collection was slightly better in the KCD arm, and plerixafor use was required more often with the use of lenalidomide. But in spite of all of that, the efficacy rates we see are superior. The VGPR rates comparing the two arms, 74 versus 61%, statistically significant. Going back again, if we want the most active regimens pre-transplant, this is an important endpoint to be looking at. So I think I actually have time to spare, but so the conclusion, I would say that young, fit patients, we're talking about the patients who are less likely to have treatment-related toxicities by nature of that definition. We see that Lendex is actually associated with longer PFS than Thaldex, and that was from initial studies, but RVD can do better than even RD based on randomized study, and that was even with the more toxic intravenous bortezomib by overall response rate, PFS, and OS. More is not always better. High-dose dex was not supported. VRCD was not supported based on their limited small study. There are very interesting frontline quadruplet regimens being explored, including the addition of daratumumab or elotuzumab, both of which were presented at ASCO, and those quads basically added a monoclonal to the triplet backbone, and very high VGPR rates, approximately 70% after initial therapy. The other point I would make is, though, when we're comparing these different regimens, it's important to pay attention to the dosing and schedule. Carfilzomib backbone, by definition, is a 28-day cycle. The bortezomib backbone is 21 days. So when we're looking at 3 and 4 cycles, it's not always the same number of days of treatment. And also, the monoclonals potentially could interfere with the detection of CR because of, especially for the IgG kappa patients. We also saw that RVD with transplant results in higher CR rates, MRD negativity, and PFS versus a delayed transplant. KRD and transplant seems very encouraging. We saw that MRD negativity based on phase 3 studies post-transplant correlates with better PFS and OS. And finally, we also have phase 3 studies showing that PI, IMiDs, and DEX yields deeper responses than PI, cyclophosphamide, and DEX. So I've highlighted here in red all the randomized phase 3 studies that would support the use of IMiD-based combinations with proteasome inhibitors frontline. So if you believe in evidence-based medicine, I think there's one answer.